Morning, dear colleagues. It's a great pleasure to be here with you. How is different fungal endophthalmitis? The question is that these are my financial disclosure. None of it is relevant to this topic. Endophthalmitis caused by a fungi is a diagnostic challenge requiring a comprehensive history and ophthalmic examination, and the most important step is establishing the diagnosis of fungal endophthalmitis and starting early treatment. And it is important to collaborate with other specialists in all cases, fungal endophthalmitis, to help facilitate the diagnostic workup and to monitor systemic therapy in contrast to other kind of endophthalmitis, such as bacterial one. Endophthalmitis is an infection of aqueous humor and the vitreous, and it can be secondary either endogenous causes or exogenous causes, but most of the cases are secondary to exogenous causes like trauma, surgery, or keratitis related, and 10% of the cases is endogenous endophthalmitis, and the fungus is the most prevalent cause for endogenous endophthalmitis. The yeast Candida albicans is the most commonly implicated fungi microorganism in the endogenous endophthalmitis, and followed by Aspergillus. And the fungal infection usually seeds the choroid first in endogenous endophthalmitis, and then often present with choroiditis, chorioretinitis, and then involve the vitreous when the infection gets worsened. And the nature of the progression is typically slow in contrast to bacterial endophthalmitis. Candida albicans is the most common fungal microbe implicated in endogenous endophthalmitis, and as you all know that the diabetes, intravenous drug use, prolonged hospitalization, catheter sepsis, immunosuppression are the predisposing factors for endogenous endophthalmitis. We expect to see a very ill patients when it comes to endogenous endophthalmitis, usually. Typically, clinical features multifocal white chorioretinal lesion, vitritis. Since this is a systemic disease, 50% of the cases are multifocal and 66% of the cases are bilateral because it's hematogenous seeding. There's hematogenous seeding from the source. However, we can expect different cases like the toenails, candida infection or something like that. It doesn't necessarily mean that the patient has to be ill to have a candidiasis and candida endophthalmitis. The typical feature is satellite lesion. It's called string of pearls, vascular sheeting, and discrete areas of vitritis may present with consolidated fungal abscess balls in the vitreous. Retinal vessel wall invasion is not seen in candida in contrast to Aspergillus cases. Here you see is a very typical example for candida infection, as there is a lot of balls, snowballs in the vitreous, and there is a projecting mass coming from the choroid protruding into the vitreous, and corresponding to that area, the OCT shows chorioretinitis and a mass going through the all retinal layers. And this is the patient got worse even if the patient was under treatment. Another characteristic feature is the ocular neovascularization in these cases. It can happen sometimes, there can be some neovascularization coming from the optical nerve going through the old infected area of chorioretinitis. Of course, after treatment, they can end up with a retinal membrane and fibrotic tissue over the macular area. After treatment, this is typically what we see for these cases. As you see here, there is a scar tissue in the retinal going through the all retinal layers, and on the right-hand side, you see very prominent epiretinal membrane as a sequela of endophthalmitis after candidiasis. Exogenous is a different cause. The aqueous humor is usually first involved in these cases, in contrast to endogenous one, and the acute onset postoperative endophthalmitis, it is not common to see fungus, but in chronic cases, chronic postoperative endophthalmitis, and even post-keratoplasty endophthalmitis, fungus should be suspected in these cases. And if the case is a secondary to trauma, Aspergillus is the most common cause of fungal endophthalmitis in post-trauma cases. Aspergillus is a little bit different and has poor prognosis. Central macular involvement is typical in these cases. Vitreous involved later when we compare to Candida. Retinal choroidal vessel wall invasion is seen, and that's why there can be ischemia and hemorrhage in these cases. We have to do something to diagnose the cases. Negative blood cultures cannot exclude the candidiasis. We have to get something from the eye, and it is the best golden standard is the vitrectomy sample for these cases. As you see here, 60% or up to 90% of the cases can be diagnosed with the vitreous step. Treatment involves all of them, but don't forget that please look at the first one. Systemic antifungal medication is essential for these cases. In contrast to bacterial endophthalmitis, it's very important. And the mild cases can be treated like just systemic antifungal cases, the flat lesion, but if the patient has some raised retinal lesion and more significant involvement of the vitreous, it should be treated with combined therapy. Pars plana vitrectomy is always a choice, and the prognosis is if the patient has poor visual acuity at the beginning and central visions were strongly predicted of sustained vision loss. How to differentiate fungal from bacterial endophthalmitis? Bacterial is more common overall, rapidly progressive, diffuse inflammatory process, but the fungal is less common, indolent and clump appearance of intraocular inflammation. As you see here, this is one of the bacterial cases, and the other is the fungal cases. On the left-hand side, there is diffuse intraocular inflammation. However, on the right-hand side, there are clumps and vitreous bands in these cases, and those are totally different. Of course, in some cases, they can be similarities, but this is the thing for the cases. So as a summary, fungal endophthalmitis is usually endogenous. Spores travel via the blood to the choroid and seed there and migrate to the other places like retina and vitreous. Bilaterality is common because it's endogenous mostly. String of pearls and projecting white mass to the vitreous is typical for candida cases. Clinical course is not as rapid as bacterial endophthalmitis. Please search for systemic predisposing factors because the patient probably are ill. Systemic antifungal treatment is essential in contrast to bacterial one. Thank you very much.
Thank you, Sybil. Excellent overview and great videos. So now it's my